All right, everyone. By my clock, it says it is up straight noon, so we will go ahead and get started. I want to welcome all of you to our webinar on prenatal opioid exposure, the impact on early childhood learning and behavior. Our presenter today is Dr. Ira Chasnoff, who is an award-winning author, researcher, lecturer, is president of NCI Upstream and professor of clinical pediatrics at the University of Illinois College of Medicine in Chicago. He'll tell you a little bit more about himself, and we'll explain a little bit more about what NCI Upstream is, I believe, as well as he gets later into the webinar. As if you've been on our webinars before, you know that in addition to our presenters, we have a few facilitators helping behind the scenes. So the top one is me, Maria Maddox. I'm one of the professional development consultants with the EI training program. And we have Alyssa Jones on as well, who is the project coordinator at the EI training program. You won't be hearing much of us. Hopefully you'll just be hearing mostly from Dr. Chasnoff, but I will pop in ever so often as needed. So at the end of this webinar, if you registered, you will get an email from the EI training program, and in that email will be a survey for you to complete. And once that survey is completed, you will get your certificate of attendance. Now, if you're listening in with someone else and you didn't actually register, you will need to register in order to get the certificate of attendance. So make sure that if you want credit for attending, that you do that. Be on the lookout. The email will come from the EI training program. Usually it comes straight into regular email, but on occasion it might get sent to your junk, so make sure that you check that. Webinars are awesome because we get to sit and do these wherever we are. We don't have to travel anywhere. Sometimes we can, some folks are doing the webinar on the go, but we can't see you and you can't see us, and you know, we miss that personal interaction. So there are a couple of ways that we are going to do that today. We do want you to interact as much as possible, and the biggest way that you can do that is through chat. So I'm just going to point you with a couple of, let me pull up my little pointer here. There we go. So you'll find at the bottom of your screen, you should have an area that says chat, and you should have a tab that says room. You can type in your questions that you might have for Dr. Chasnoff as he goes through the webinar. Any experiences that you may have had. As you can see, we've just been kind of talking about where we're logging in from and the weather. Say hi to those of you who you haven't seen each other in a while. Share strategies that you may have found. Anything that you want to talk about in the chat, please do so, because that will help us stay engaged together. But for certain, you want to, if you have any questions at all, you don't have to wait to type them. As they come to your mind, go ahead and type them in. And we may not address it right at that moment, but because it may be a question that Dr. Chasnoff is going to cover later on, or we also have built-in question breaks during the webinar that we will go back and look at all the questions that have been typed up and address them at that time if we need to. So make sure that you post any questions that you have. You'll also notice, since I've got this screen up, you can see who all is logged in right now. We've got 88 folks logged in, and more are coming as we continue to talk. So anyway, so you can kind of see who all is actually participating in this webinar today. We will also do another way of participating, and that is through the use of polls. But before I get to that, I want to point your attention to the upper part of your left-hand screen, where you should see a section that says Participants, and your name, and then there are 4 icons under your name. The first one is basically an emoticon kind of icon, so you can click on that and put in whatever you want, say how you're feeling today, and you can use that, you know, expressing pleasure or interest or whatever else you want. We'll skip the second one. The third one is the hand-raising tool. So just to make sure that we all know it works, can everyone hear me? If you can hear me, raise your hand. Awesome. I'm seeing lots and lots of hands going up. Perfect. Great. Great. So awesome. So now to unraise your hand, you just click it again. Hang on, I'm going to do the poll yet. I haven't done that yet, guys. Just click your hand back and it'll unraise your hand. And you should see, you'll know if your hand is raised or not because you'll have a little hand raised next to your name. All right, so the other way that we have participating is through the use of polls. So the fourth icon under your name, now let me fix that. I don't have the poll set up correctly. Let me set that up. All right, so under your name, the fourth icon should now have a little letter in it. If you click on that, you'll have 5 options that you can choose from. So I'm going to go ahead and open it up and have you identify who you are participating with us today. So go to that fourth icon, click it, and click the appropriate A, B, C, D, or E response. We'll give folks a few seconds to do so. Even if you've typed your response into the chat box, because I wasn't ready yet, go ahead and put it in the poll as well, because I will be able to then post the results here in just a little bit. This gives Dr. Chasnoff and myself and everyone else kind of an idea of who all is in the room with us today. So we'll give you a few minutes to find that polling function, that fourth box under your name. All right. See how many folks that we've got here. And Luis, I see you have a question. So if you would type your question into the chat box, that would be helpful, and I can address your help there. So if you have any questions, go ahead and post them in the chat box. All right. I think I've given folks, most everybody, enough time, so let's just see who we have in our webinar today. So within our webinar, it looks like we've got almost half of you are EI providers, and looks like we got some CFC staff there, some others. So we've got a good mix of folks. We are going to also do another poll here, and just let me clear this. And just to be a little bit more specific about what your discipline is, go ahead and enter the poll again. Go to that fourth box under your name and identify what your discipline is. So obviously if you are CFC staff or other, you don't need to respond to this one. Okay. As far as other being like administration, but yes, clinical social worker, great, yes, please put those things in there, okay? All right. Give folks a few seconds to respond to that. That fourth box under your name, you click it, you will then be able to open up the polling function and choose your A, B, C, D, or E that way. Okay. Oh, yeah, and some of you may be participating via phone or so if you have to chat your responses that way, that's fine. Okay. All right. I'm going to go ahead and post the responses here. Let's see what we've got. So of those of you who are early interventionists, it looks like we've got a handful of developmental therapy providers. We've got some speech-language pathologists. We've got a little bit of everybody. Lots of service coordinators, DTVs, some nutrition therapists, social workers. So we're kind of running the gamut of EI providers in here. Awesome. Love to kind of spread the word amongst all of the disciplines. This is great. All right. With that being said, Dr. Chasnoff, I'm going to let you talk a little bit about yourself and then tell us all about prenatal opiate exposure. Doctor?
Thank you, Maria. Welcome to everyone. I'm glad to be talking with you today. You know, I know you came to this webinar thinking you're going to hear about the brain of infants exposed prenatally to opiates and about the medical and the neurodevelopmental difficulties these infants exhibit, but there's an overriding point that we need to address in the very beginning. And no matter what your discipline or your expectations as you come into this webinar, I want you to remember as we go through all of the information today is that children grow and develop in the context of relationships. And what we're talking about, of course, is attachment. And so I want to make sure everyone understands what we mean when we're talking about attachment. Attachment is the interconnectedness between human beings, and it requires two things. It requires each of the people in the relationship to read the other one's cues and then to respond appropriately to each other's cues. Now, that's really important because as early interventionists, as clinicians, we hear the term attachment disorder. And we immediately think, if a child has an attachment disorder, oh, that mother must not be a very good mother. She hasn't given this child what he needs in order to develop a strong bond, a strong attachment. But what you have to remember is attachment is a two-way street. And not only must the mother be able to read her baby's cues and respond appropriately, but the infant must be able to read his mother's cues and respond appropriately. Now, I do have mother here. I'm saying mother, but you can substitute any word you want. Father, caregiver. Caregiver sounds too clinical to me. But we're talking about the mother person, whoever is that primary person in the child's life. Now, the question then, when we talk about attachment, is where do we start? And we're going to start on the maternal side of the relationship. And we're going to go way back into the prenatal period because that's when attachment begins. And that's when risk begins. And we're going to go far back into the embryonic period. Now, what is the embryonic period? The embryonic period is the first 12 weeks after conception. And during that time, the cells that form the embryo are undedicated. They're known as stem cells. So, in other words, the cells of the embryo in that first 12 weeks after conception don't know which direction they're headed. Some will become muscle, some will become bone, but they're undedicated stem cells. And it's during this first 12 weeks after conception that gestational stress can mark the genes. Now, the process is known as methylation. The methyl group is a chemical grouping of elements. It's one carbon atom and 3 hydrogen atoms, CH3. And if a pregnant woman is undergoing stress, especially intense emotional stress, which can be engendered anyway from verbal abuse, physical abuse, or dire poverty, stress during that first 12 weeks will cause a methyl group to attach to the stem cell. And that changes the genetic makeup of that cell. So the genes can be changed through fetal experience. And during this time, the mother in good times is passing serotonin to her unborn embryo. And serotonin is responsible for creating the neuronal circuits in the frontal brain. When the mother is stressed, experiencing fear, anxiety, cortisol is transmitted to the fetus and disrupts the development of these neuronal circuits. So during the fetal period, beginning in the embryonic period all the way through the fetal period, the fetus is learning what to expect in the outer world. Now, the two essential caregiving qualities, as I mentioned, are the mother must be accessible, that is, reading her infant's cues, and must be responsive, responding to the infant's cues. So with the biological activity going on with possible methylation of the genes and the environment in which the woman is living, there are factors that are going to affect how well that woman is going to be able to attach to her fetus and to her infant. And from our research, we have found there are 6 primary factors that affect the ability to attach. The first is negative heritage. The woman comes from a family history, and if you're familiar with the ACEs studies, you know that early childhood experiences set the pattern for lifelong difficulties. So during early childhood, if the mother was living in a home where there was substance abuse, where there was violence, where one of the parent figures was incarcerated, the woman brings this history to her own relationship with her infant. There's emotional instability primarily related to that early trauma. And in our own research and others, if you're working with a woman who has a history of substance abuse during pregnancy, there is a high likelihood that she suffered significant trauma early in life. And from our own research, what we have found, that trauma most often takes the form of sexual abuse. Now think about that for a moment. A woman who is currently using substances during her pregnancy and has a history of sexual abuse in her childhood, think about how that would prepare her for motherhood. The third point is a lack of social support. Children who grow up in
Okay, Dr. Chasnoff, it looks like your audio is on delay for a moment. So folks, and it looks like we've lost him. So let's, I'm going to wait for him to log back in, and we will try this again. So just hang tight. I could do a song and dance, but you can't see me, so we will just wait for him to come back on. Let me put him back up in here. There we go. Doctor, we lost you, but you're back now.
Oh, I'm not sure what happened. I've just been talking away here.
We lost you at about where you were asking about, think about what that means about women who've been sexually abused.
So think about that in preparing this woman to be ready to have a relationship with her own infant. The third marker is a lack of social support. The women who grow up in a family where there's substance abuse, where there's violence, are socially isolated. These are avoidant families. They avoid social systems of support. And a woman who grows up in that kind of family is going to grow into an adult who is socially isolated. And if there's one factor that differentiates men and women in the context of human development, is that women's lives revolve around relationships, primarily relationships with other women. And that's key to adult female development. But if you're working with a woman who has a history of chemical dependence, that woman has not had relationships with other women. She has competed with other women for love, sex, drugs, money. And so she does not trust anyone. The fourth component is cognitive functioning. Now, these are MRIs. The two on your left, top and bottom, are two cuts of an MRI looking from back to front at an adult female brain, and these are normal MRIs. The two on your right are two cuts, the same cuts, of an MRI back to front of an adult alcoholic woman. Now, I'd like you to compare the top left and right. And what difference do you see between these two MRIs? Well, it's pretty obvious. If you look at the upper left, you see the black holes in the middle of the brain. Those are called ventricles. And the ventricles are the empty spaces in the brain through which spinal fluid flows. However, alcohol kills brain cells. And what happens in the chronic alcoholic, whether it's a man or a woman, is the brain cells around the ventricles die off. And so the ventricles expand. And this is how you get decreasing cognitive functioning in someone with a history of chronic alcoholism. The bottom two left and right MRIs, again, are on the left normal, and on the right the alcoholic woman. And if you look carefully, you can see right above the ventricles on the left side, there's a kind of U-shaped structure. This is called the corpus callosum. And the corpus callosum is responsible for connecting the left and right sides of the brain. Now, if you look at the right bottom MRI, you can see the ventricles again. They continue to show how expanded they are. But then look at that U-shaped structure. Look at the corpus callosum, and you see that it's thinned out. This is called, appropriately enough, thinning of the corpus callosum. Now you may say, well, so what? The corpus callosum, as I said, is what carries information between the two sides of the brain. To take information you know cognitively and move it to a higher regulatory level, you must be able to communicate across the corpus callosum. Now, I'm sure that you've come across this problem in your work. You're an early intervention specialist. You have a woman with her baby. You have your first appointment. Things go well. You're feeling pretty good about it. And you say, terrific, let's get together again next week. Let's say next Thursday at 4 o'clock. And the woman puts it into her smartphone, says, okay, it's on my calendar, 4 o'clock next Thursday. Next Thursday arrives. It's 4 o'clock. Where is she? She's not there. 4:15, 4:30, 4:45, she comes strolling in. And you look at your watch. You say, what time is it? And the woman looks at her watch. She says, it's 4:45. And you say, what time was your appointment? She says, 4 o'clock. That's an example of a deficit in executive functioning, the ability to plan and complete a task, which one of the difficulties, one of the changes in the brain that can produce difficulties with executive functioning is thinning of the corpus callosum. So it's not that the woman doesn't care about her infant's progress. She simply has difficulty taking cognitive information, something she knows, such as be there at 4 o'clock, and moving it to a higher regulatory level. So I hope you see, as we're talking through this, how these kinds of changes in the functioning adult brain can affect the way the woman not only interacts with you, but interacts with her infant. The fifth factor is psychological functioning, and we know from extensive research that women, compared to men, women with substance abuse issues have a significantly higher rate of co-occurring mental health disorders. And the two most common diagnoses we find in pregnant and parenting women with a history of substance abuse are depression and borderline personality. Depression is pretty straightforward. I'm sure you understand how that could affect a woman's relationship with her infant. But borderline personality is an individual who is very egocentric. They have difficulty not only sympathizing, but especially empathizing with others. And they look at the world as everything that happens in the world, they understand it only in the context of how it affects them individually. And so again, a woman who might be depressed, have a borderline personality, think of how she's going to be able to relate to her infant. And the final factor, which plays in to all of the rest, is substance abuse. Now, this is a simplified example of the attachment system in humans. And I'd like you to start over on the left-hand side where it says maternal brain and endocrine response. Now, there are two systems in the body, in the brain, that regulate or promote attachment. The first is the dopamine receptor system, which exists primarily in the prefrontal cortex of the brain, and the other is the oxytocin system. Oxytocin is a hormone produced in the hypothalamus that promotes attachment. Some people call it the cuddle hormone. Now, I see from the chat box that you're having trouble. Some of the audio is not up to the slides. So let me pause a minute and maybe the audio will catch up. So we're going to start here now at the maternal brain and endocrine response, mediated through the dopamine and oxytocin systems. The maternal caregiving environment, both prenatally and postnatally, stimulates the fetuses and the infant's development of dopamine and oxytocin. And that's what's responsible for infant attachment behavior. You, of course, have ongoing environmental influences, but that infant, through life, grows up into an adult who has developed his or her own attachment strategy. And this is the normal cycle of attachment, again, based in the dopamine and oxytocin systems. What does that have to do with our discussion today? Chronic administration of drugs of abuse, such as opiates or cocaine, reduce oxytocin levels in the hypothalamus. So now, besides all of the environmental factors, the psychosocial history of the woman who is becoming a parent, we now have a biological impact on the ability to attach. And what happens is this attachment cycle gets disrupted. So if a pregnant woman is using drugs, those drugs will reduce oxytocin levels in the hypothalamus, decrease oxytocin levels, then in the mother produce lower oxytocin levels in the infant, the fetus and the infant. And so you get a disruption of infant attachment behavior right there. Now, someone asked if I could explain the dopamine system. I'm going to talk a lot more about dopamine in just a moment. So, are there any questions?
Yeah, I see Kristen has her hand up. So, Kristen, if you have a question, you can go ahead and put it in the chat box. That will help. Okay. Otherwise, I've been watching monitoring the chat box, and other than the dopamine question, it looks like that was the only question really so far. So okay. There may be some folks that, it looks like there are a couple of folks that are typing. Lisa has a question here about if stress toward the end of the pregnancy can have the same effect as it does in the beginning.
Yeah, stress during pregnancy in the last trimester does not have the same effect. The methylation occurs only with the stem cells, during that first 12 weeks of gestation.
All right.
How does the dopamine oxytocin system relate to Stephen Porges's polyvagal theory? It probably does. I can't give you that direct connection. We know that especially dopamine does impact the vagal system, but I don't think any of us are yet smart enough to know how this all comes together. The question here, how are you going to go into nature versus nurture? Especially as related to adopted children, yes, we will get to that. Does breastfeeding help the production of oxytocin? Absolutely. When a woman breastfeeds, she increases oxytocin levels in both herself and her infant. And so it's well known that breastfeeding promotes attachment, and that is the biological mechanism, is through the oxytocin system.
Wonderful. All right, I'm not seeing any more questions, but folks, don't be afraid to post your questions as you think of them. That way we can address them, have them ready to go during the question breaks. And while we're waiting to see if there is any other last-minute questions that come up, we do have a poll out here for you. And so if you would go back to that polling function, that fourth box under your name, and identify of the substances that are listed, which one of these are not considered an opioid. So we'll give you, it's that fourth box under your name, the one that has the letter A in it. Open that up and make your choices. Okay. Give folks a few seconds to kind of think that one through. Folks are logging in here, putting their answers in, so give a few more seconds here. This is the waiting part's the hardest part. All right. If you haven't already done so, please go ahead and make your choice. If you're on your phone, Dana, it probably isn't possible for you to make your choice via the polling function, but you can put your choice in the chat box if you so choose. All right, so let's see what we got. Of the individuals that responded, the vast majority, 40% of folks, said that methamphetamine is not considered an opioid. But then we had a mix of everyone. There were a few people that chose one of each of those. So what do you think, Doc?
Yeah, the one substance that is not an opioid is C, methamphetamine. This is an important point because when we talk about neonatal abstinence syndrome, NAS is very specific to opioids. No other substance produces neonatal abstinence syndrome. Now, of course, we're going to get much further into this, but the answer here is methamphetamine.
Thanks, everyone.
So I've set you up with this early part of the discussion, which may be something you didn't quite expect in a talk about opioid use during pregnancy. But again, I just want to make sure you understand that not only do children grow and develop in the context of relationships with their mother or their family, they grow and develop in the context of their relationship with you as an early intervention specialist. And your relationship with the mother, with the family, and with the infant is of prime importance as you develop your intervention strategies. So let's talk about attachment from the child's perspective now. And this is where we get into dopamine. Substance abuse primarily acts on the catecholamine system. And you're familiar with catecholamines. Catecholamines, dopamine, serotonin, norepinephrine. And what happens is when you, let's say, want your fingers to wiggle, you send an electrical message from your brain to your fingers to wiggle. And of course, there's not one long nerve that it connects your brain to your fingers, but it's a series of nerves. So that electrical stimulus must travel down the nerve pathway to the end of the nerve, and then must be transmitted across the nerve gap to the beginning of the next nerve. So catecholamines are also known as neurotransmitters. And the primary neurotransmitter involved in substance abuse is, in fact, dopamine. So here's what happens. The electrical stimulus travels along the nerve pathway. Dopamine picks up that stimulus, carries it across the nerve gap, releases it, and then dopamine circulates back to the proximal nerve ending. This is called reuptake. And so that's how your fingers know when to stop wiggling, because dopamine, because of the process of reuptake. Now, dopamine, located primarily in the prefrontal cortex, the front part of the brain, is known as the regulatory center of the brain. But dopamine also is the pleasure center. So when you eat food, you release dopamine. In fact, from baseline, eating food, any kind of food, increases dopamine levels about 125%. When you have sex, having sex raises dopamine levels 150%. So you can see there's not that much difference between eating and having sex. If you smoke a cigarette, nicotine raises dopamine levels 200%. Cocaine raises dopamine levels 300%. Methamphetamine raises dopamine levels 1,000%. So the reason people use drugs is to get that dopamine high. It's that rush of dopamine. And we can look at a number of different drugs. This happens to be methamphetamine. Methamphetamine increases dopamine levels by enhancing dopamine release. So when somebody uses meth, there's a massive amount of dopamine that crosses the nerve gap. For cocaine, a normal amount of dopamine crosses the nerve gap, but then as it circulates back, cocaine blocks dopamine reuptake. And so what you get is excess dopamine at the distal nerve ending. Opiates are a little more complex. There are 3 types of neurons that participate in the action of dopamine. And what I've tried, the action of dopamine. Now, what I've tried to do here is illustrate this as best as possible. The green are the opiates, in this case, morphine. The opiates attach to the opiate receptors in the nucleus accumbens, and when the opiates attach to the opiate receptor, this sends a signal to decrease the release of gamma aminobutyric acid, known as GABA, G-A-B-A. Now, what GABA does is it inhibits dopamine release. So there's less dopamine being released, which then, if the receptor is blocked by opiates, then there's no signal to inhibit dopamine, and so the contrary signal is sent to release more dopamine. So it's the opiate attaching to the opiate receptor that interferes with GABA inhibiting dopamine release. And so when someone uses opiates, you get increased dopamine release. Clinically, what happens during pregnancy is with increased dopamine release, there's action on the smooth muscle. Now, one of the major effects of dopamine is acting on smooth muscle, which is why anyone, when they smoke a cigarette, as we said, nicotine increases available dopamine. So one of the first things that happens when you smoke a cigarette is the dopamine acts on smooth muscle, the major smooth muscle of the body being the heart, so you get a rapid heartbeat. The other place that there is smooth muscle is surrounding all the arteries, so that there is constriction of smooth muscle around the arteries. So your arteries are now clamped down. The heart is beating hard and fast against arteries that are constricted down. So what happens to blood pressure? It goes up. So what that translates into is when you hear somebody died of a drug overdose, the primary findings on autopsy are strokes and heart attacks. Now, during pregnancy, the major smooth muscle organ of half the population of the world is the uterus, which is why there's such a high rate of preterm labor and delivery in women who use substances, including nicotine. Also, the excess dopamine acts on the smooth muscle surrounding the umbilical arteries, so the umbilical arteries constrict down, impeding flow of blood across the placenta from the mother to the fetus. And with a lack of blood flow, there's poor oxygenation, and with decreased levels of oxygen getting across to the fetus, you then get low birth weight. And that's what produces the low birth weight, low birth length of infants whose mothers are using opiates during pregnancy. And in fact, if the opiate use is heavy enough, this will impede brain growth. And the way the head grows is by the brain pushing out on the skull. So if the brain isn't growing well, you get a small birth head circumference. There also are increased rates of stillbirth and following delivery, increased rates of sudden infant death syndrome. It appears that the rate of SIDS is about 10 times higher in infants whose mothers have used substances during pregnancy. But let me caution you, statistically, the number one drug that puts an infant at risk for SIDS is in fact nicotine. And in our own studies, we find among women who use tobacco has a 3 times increased rate of producing low birth weight and risk of SIDS than does cocaine, if mothers also use cocaine. So there are multiple substances of abuse, opiates being only one of them. Now, I think most of you are familiar with the medical complications of pregnancy when a woman is using opiates, but the difficulties we get into when we observe infant behavior become much more complex. Now, webinars are difficult to communicate some very confusing information, but I'm going to try to show you the basis of neonatal abstinence syndrome. So when a baby is born, if he's been exposed to opiates all through pregnancy, with opiates attaching to the opiate receptors, and the opiate receptors being blocked from regulating dopamine, so you get high levels of dopamine release. When the baby is born, and he no longer has that supply of opiates, this is the pathway that occurs. You get high activation of adenyl cyclase, increasing levels of cyclic adenosine monophosphate, which produces higher levels of protein kinase, transcription factors, and elevated release of all neurotransmitters. And let's start with the pink circle to your right, dopamine. So you're getting decreased levels of dopamine compared to what the baby was expecting from during pregnancy. And so that's where you get the hyperirritability and the anxiety levels that you see, which some parents describe in the infant who is going through neonatal withdrawal. The acetylcholine is what produces the gastrointestinal and respiratory findings: diarrhea, vomiting, yawning, sneezing, sweating. You get other increase in receptor activities, and that's where you get the sensitivity to pain. Noradrenaline increases are what produce the fevers, the high blood pressure, tremors, tachycardia. You get decreased serotonin, which is you see in the infant as sleep deprivation and difficult sleep patterns. And you get corticotropin increases, which is where you get the increased stress and hyperphagia that you see. So the whole picture of neonatal abstinence syndrome can be explained through this dopamine and neurotransmitter receptor system. Now I'll give you some. Somebody asked, I do not know what all those words were in the green center. Let's go back. These are all part of the different aspects of brain functioning and how the brain regulates different aspects of daily bodily functioning. And I don't think the words per se are as important in the middle of the screen as the circle around all. We're going to go through all of this much more carefully, but what I was trying to show you is that I know most of you are familiar with neonatal abstinence syndrome. I'm trying to show you that it's all through the neurotransmitter systems that the different difficulties that we see in the infants are all embedded in the neurotransmitter system. Hopefully this will become a little more clear in a moment. So Patrick has jumped way ahead, about 15 slides ahead. How do we get into treating the illness instead of just masking the symptoms? Good question, and we're going to talk about that.
Other than the questions that you have already addressed, I haven't seen any other ones come through, so I think we're probably good to move forward.
Okay. So here's some key questions that we have to look at, and this kind of gets to Patrick's question. How do we treat children, infants who are going through neonatal withdrawal? And I would counter with the question, is it really withdrawal? And is withdrawal the same as abstinence? The other issue is, what's neurobehavior? And how does neonatal abstinence syndrome differ from neurobehavior? Because the treatment approaches are different. As we look at this question, we also have to ask, what are the factors that affect diagnostic labeling? I'll just give you an example of why that's important. We did a study several years ago, well, it was over 20 years ago, and we enrolled hospitals from across the country, And in brief, we audited the charts of babies, all babies, and there were about 25 hospitals nationally. And we audited all infants who were admitted to the neonatal ICU, whose mothers, we matched them to their mothers' charts, and we audited the charts of infants whose mothers had a documented history of opiate use during pregnancy. So what we're looking at is infants in the neonatal intensive care unit whose mothers used opiates. And our question was, what are the symptoms they're showing, and what is the discharge diagnosis? And in brief, what we found was that infants whose mothers had used opiates during pregnancy and had all the signs that we associate with neonatal abstinence syndrome, irritability, crying, on and on, there was a difference in the discharge diagnosis based on the race and socioeconomic class of the mother. If an infant was born to a mother who used opiates during pregnancy, that infant's discharge diagnosis, if the mother was black, was neonatal abstinence syndrome. But when you match that infant to a white infant whose mother used opiates and the infant had the exact same symptoms, but he's white, the discharge diagnosis was seizure disorder. So there are racial and social class biases that affect how diagnoses are given. And that's one of the things we're going to look at. So finally, is it in fact important to differentiate NIS and neurobehavioral difficulties? Does the diagnosis affect treatment? So let's address this question now. And we have to make sure we're clear on our definitions. Addiction is when an organism, in this case a human, engages in a compulsive behavior. The behavior is reinforcing, and there's a loss of control in being able to limit that behavior. Dependence is a state in which an organism functions normally only in the presence of a drug, and is manifested as a physical disturbance when the drug is removed. Abstinence is the practice of restraining oneself from indulging in something. Withdrawal is the unpleasant physical and mental effects that result when you stop doing or taking something. And neurobehavior is the relationship between the nervous system and behavior. Now, these may seem like subtle differences, but one of the things I would challenge you with is neonatal abstinence syndrome the same as neonatal withdrawal? And are babies born to opiate-using women who are going through neonatal abstinence syndrome, are those babies addicted? Now, why are these such difficult questions? The research relies on pretty selected samples, and those samples of infants are very small. And there's a great deal of difficulty associated with prospectively collecting measures of substance use. So when we have an infant with neonatal abstinence syndrome, we don't know how much the mother used, and we also don't know what other factors played into the infant's difficulties. In fact, what we're looking at neonatal abstinence, or is it neurobehavioral difficulties? Because the mother used other drugs besides the opiates. There are differences in study designs and outcome measures. There's a lot of confusion in the literature on terminology. And you will see it when you read articles that people confuse addiction with dependence, abstinence with withdrawal, NAS, neonatal abstinence syndrome with neonatal dependence syndrome. There's the problem of polydrug use. Women tend to be polydrug users. And I would challenge you to find any woman who used only one type of drug. And then most of what we know about abstinence comes from what we know about adults who are going through drug withdrawal. But the physiology of adults doesn't necessarily translate to understanding the physiology of the fetus or newborn, because the fetus is much more complex. The neurological development is much more immature than the adult, and the processing, the way the infant is able to process information, differs. You have the interaction between the maternal, fetal, and placental pharmacokinetics, and drugs last longer in the fetus. So what particularly is neonatal abstinence syndrome? It's the collection of signs and symptoms that occur when a newborn prenatally exposed to opiates experiences opioid withdrawal. You can in fact find it in the research literature where people talk about neonatal abstinence syndrome in infants who are not exposed to opiates, but other substances. The other thing you will find is various studies that say that in opioid-exposed infants, the rate of neonatal abstinence syndrome, some studies say 2%, 11%, 55%, 94%. So you can see there's a basic problem in the research literature. There's also the misuse of the term addiction. And it is not addiction in the newborn. The newborn is not engaging in compulsive behaviors that are hard to control. That is, trying to get more drug, having drug-seeking behavior. But does it represent dependence? And should this be called neonatal dependence syndrome rather than neonatal abstinence syndrome? NAS, the classic terminology, can be present at birth. It depends on when the mother last used opiates. The symptoms usually peak around 3 to 4 days after birth. There is an acute phase up to about 6 weeks, and then a subacute phase up to 7 to 8 months. And we've published extensively on this this phasing of neonatal abstinence. Now, you do have to be careful because there are some drugs that cause psychomotor behaviors in the infant that are consistent with withdrawal. And I've listed them here. I'm not going to go through the symptomatology for each of these. You have them on your handout. But these are the kinds of pictures you can get with some of the other substances that can look like neonatal abstinence syndrome. But by definition, this is not neonatal abstinence syndrome. NAS refers only to opiate-exposed infants. Now, neurobehavior is related to the relationship between the nervous system and behavior, as we noted, and it really measures, when you talk about neurobehavior, you're talking about the infant's interaction with and response to internal and external environmental stimuli. And as you sit at your desk watching this and listening to this presentation, you have all sorts of other things going on around you. There may be office chatter down the hall. There may be somebody knocking on your door. Neurobehaviorally, you are shutting those kinds of sounds and other stimuli out so you can focus and learn here. That's neurobehavior. Now, this is just a partial list. Almost any substance a woman takes will produce some neurobehavioral changes in the infant. And there's a wide literature on infants who have been exposed to these substances. So how can we understand neurobehavior? We're going to look at neurobehavior through an information processing model. And I hope that we'll be able to, that you'll be able to understand the difference between neurobehavior and neonatal abstinence by thinking of it this way. There are 4 domains of information processing: input, integration, memory, and output. Input is the way you bring information into the brain. Integration is how you pull all that information together. And I'm sure all of you have heard of sensory integration. Memory is storing that information for later use. And output is your appropriate response to the stimulation. Now, the way it works, these are the different parts of the brain. I'm sure all of you are familiar with this. And you can see the frontal lobe, parietal, occipital, the cerebellum, the temporal lobe. An important area right up here in the front is the prefrontal cortex, which, if you remember, is the primary storage house of the dopamine receptor system. The important thing to understand is that information enters through different pathways. So anything you see, visual information, enters the eye, travels along the optic nerve, and inserts in the occipital lobe of the brain. That's the visual cortex. So you actually see with the back of your brain. Auditory information enters the ear, travels along the auditory nerve, and inserts on the midline of the brain. And taste, touch, and smell enter the parietal lobe. The job of the brain is to integrate that information so it makes sense. When necessary, store it in memory. And when it's time to use that information, the information shoots forward to the dopamine receptor system, where dopamine fires off and tells you how to respond. Let me go back a second just to give you a concrete example. Let's say you're walking along a sidewalk and you see a car coming. That image of the car enters the eye, travels along the optic nerve, hits the occipital lobe, flash, there's the car. That information shoots forward to the prefrontal cortex, where dopamine fires off and says, stop walking. That's behavioral or motor regulation. Any activities that you perform through the day are grounded in information processing. And all of the sensory input you get through the day comes from these different directions, are integrated, and are regulated through the dopamine receptor system. And you'll notice I'm using the word regulated quite a bit. Now, in the infant, there are 7 domains of neurobehavior that we look at. There are 2 major ones that are affected when an infant is exposed prenatally to substances, including opiates. The 2 are orientation and state regulation. The way to test orientation, if the infant, and this is for birth through 28 days of life, this works. So if the infant is lying on his back in a quiet room and you ring a bell, a normal infant will show alerting behavior. He's heard the sound and will orient. That is, he'll turn his eyes and perhaps his head toward that sound. And if you give him your voice, he will turn toward your voice. That's auditory orientation. Visual orientation is if you give him, for example, your face. The infant will look at your face, and in fact, even newborn infants will do some tracking peripherally. Newborn infants can't cross the midline, but they'll look you in the eye and they'll track your face for a short distance. Those are normal infants. Now, infants who have been exposed to substances, especially opiates, when you ring that bell or when you give the infant your voice, instead of, the infant will show alerting behavior. He will have heard you, but instead of orienting toward your voice, he won't know where to go. He won't be able to orient toward the sound. And if you give him visual input, such as showing him your face, he may glance at you briefly but will move away. It's called gaze aversion. He cannot tolerate that kind of visual input, especially a human face. And if you keep persisting, trying to get the infant to orient toward your voice and toward your face, the infant will rapidly escalate. This is where we get into state regulation, the ability to regulate states of arousal. Normal infants, if you've seen a normal infant sleeping, will begin to awaken, may reach an alert responsive state, and may even escalate eventually to crying. But infants, newborn infants, have self-soothing capabilities. The infant will bring his hands and arms, his legs to the midline. Some people call it a fetal position, but it's really a midline position. They may rock their head. These are all soothing behaviors. The ability to regulate down, to self-soothe from crying. Infants who have been exposed to substances, we're talking today about opiates, but this is where marijuana really comes into play also. These infants have difficulty with state regulation, so they may be crying, they may be quiet and sleeping, and will suddenly be irritable and crying, and then bounce back down to a deep sleep again. So it's what I call yo-yo behavior. These are difficulties with state regulation, and you can imagine how difficult it makes it to care for an infant who, with very little stimulation, nothing going on externally, will be so erratic in his ability to regulate his states of arousal. Somebody just asked a question, so let me address that because it's a good question. Is this a good argument for the need to have attachment and sensory integration before one can appropriately produce sounds and words to communicate? It's important to have attachment and sensory integration before one can do anything else. I think sensory integration, sensory processing, is at the heart of the difficulties that we see in the children, both short-term and long-term. And I hope there are OTs on this webinar that are well-trained in sensory integration, because we need lots more of that kind of service available to infants and children. So these are the neurobehavioral difficulties. Now, if you think about this, you can see how these state regulation issues can look like neonatal abstinence. And Jenny's question brings up an important point. Are we going to treat an infant who's having these difficulties with regulating state of arousal with medications that are used to treat neonatal abstinence? Absolutely, the question is no. Sensory integration approaches are the way to treat these infants. We're going to get a little bit more into that in a moment. Oh, in fact, it's this slide. So how do we intervene? And Patrick, several slides back, asked the question, well, how do we treat the infants? We are not going to use medication, and we've done extensive studies on this. Very few infants actually need medication to get through neonatal abstinence, because a great deal of what we see in the infants is neurobehavioral difficulties rather than true neonatal abstinence. So you always start with supportive measures. Swaddling the infant tightly in a flexed position, bringing hands and legs to the midline. using a pacifier, and use of a pacifier sucking on a pacifier raises internal opiate levels. So you can see how that would be helpful. Low lighting, an oscillating crib, and avoidance of abrupt changes, along with frequent small feedings. Now think of your typical neonatal ICU or even your normal newborn nursery, and you can see why these infants do not do well in that kind of environment. For neonatal abstinence syndrome only, we use pharmacologic interventions. Our indication for using medication is either significant vomiting and diarrhea so that the infant is not growing, or seizures. We rarely use medications for the infants that we work with, but when we do, there are a variety of medications that can be used. It varies quite a bit in the Chicagoland area and across the country. I see we have some people from Ohio on here, and I'm going to be speaking on this very subject in Ohio, I think this fall. But in Illinois, I think methadone is probably the most common medication being given to infants, followed by morphine. Morphine drops are probably the best approach. Do we have other questions at this point?
So it looks like Patty has a question about erratic abilities to self-regulate similar to those seen when an infant has hyperactivity. Do you see that one there?
No, I don't. Let's see. My screen isn't big. I'm trying to scroll down. Let me go in the order that I have them on my screen, and then if I've missed anything, Maria, then you can bring it up. Barbara asked, often EI goals are written that speaking will regulate a child's frustration levels. I don't know if you mean speaking to the infant.
I think she may be referring to maybe an older child. So, Barbara,
okay, let's stick to the newborns, the infant right now. We do use
the infant learning to speak. The infant learning to make sounds.
No, we want to speak to the infants. I think the key is, if you're working with an infant with neonatal abstinence, you have to read the infant's cues. If the infant gets easily overloaded by auditory information, then you need to try to give the child more visual information rather than auditory. But you don't want to not speak to the infant. Certainly, that's how infants learn to speak. I'm not quite sure what this question is asking.
Maybe Barbara can rephrase it, and we can address it in the next break. Mm-hmm.
Oh, here's Patty's question. Are the erratic abilities to self-regulate similar to those seen when an infant has hyperactivity? Hold on to that question, Patty. It's a great question, and we're going to get there. Many NICUs are using infant massage and containment techniques to support the babies. Yes, we do use infant massage. I think the best research showing the benefits of infant massage have been done down in Florida. Tiffany Field, if you want to look further into infant massage. But yes, we do use infant massage. What about mothers who are using something like methadone during pregnancy? Methadone is an opiate, and that's a whole other webinar on methadone use in pregnancy. But those infants will go through neonatal abstinence syndrome if the mother was on methadone.
Barbara will rephrase her.
Tiffany Field.
Yeah.
Okay.
Oh, I think we're caught up.
Okay. So, what's the difference between withdrawal and neurobehavioral deficits. I've tried to make it easy for you. Here's a chart. We all like charts. And I've listed to the far left the different symptomatology, the different systems that are affected, and then under the NAS and the neurobehavior. And I'm not going to go through this point by point. You can read through it. But what I want you to see is that it's the autonomic nervous system that really is most different between NAS and neurobehavior. And so that's something you can specifically look for. I teach new parents, whether they're biologic, foster, or adoptive, that you have to read the infant's cues and understand stress. And a sign that an infant is getting stressed, the earliest signs of stress are yawning, sneezing, and hiccuping. And yawning, sneezing, and hiccuping occurs quite frequently in neonatal abstinence syndrome. If a baby with neurobehavioral difficulties becomes overloaded and you don't pay attention, that baby will start yawning, sneezing, and hiccuping. So when you see that, whether it's NAS or neurobehavioral difficulties, you have to step back. And that's when you know to start using your swaddling and your pacifier. You don't want to allow an infant to get completely dysregulated, just crying and irritable, because it's almost impossible to bring them down. We can come back to this chart if anybody has questions about it. So now we get into what happens. Now we're going to focus on the 0 to 3 child, but this has to do all the way through adolescence. If you want to understand, if you want to take what we've been talking about in the infant and apply it to the growing child, think about the child from the perspective of information processing and the neurodevelopmental difficulties that can result from deficits in information processing. There are 3 categories: neurocognitive functioning, self-regulation, and adaptive functioning. Let's talk about each one of these individually. Neurocognitive functioning, one of the key elements is IQ, or global development. And in substance-exposed infants, for any substance you can name except alcohol, you're going to get normal cognitive functioning. So doing an ASQ, a simple ASQ in tracking development, or any other kind of developmental screener, these babies are going to do fine. And unfortunately, what happens, because they will screen normally on a general screener, they don't get moved on into the early intervention system. However, where you do, in infants exposed to opiates, do get early signs of deficits, are looking at executive functioning. Now, I mentioned executive functioning earlier. It's the ability to plan and complete a task. Executive functioning requires every part of the brain. And so no matter what drug the woman takes, whether it's alcohol, opiates, marijuana, methadone, go across the board, they all impact executive functioning. And you can start screening with executive functioning starting at about 2.5 years of age, looking at using an instrument called the brief inventory of executive functioning. Now, I realize that is not the norm in early intervention programs, but I'm going to give you a way to look at executive functioning in the young infant in just a moment. The second area is self-regulation. This is where you get into the regulatory problems. So yes, the person, I don't remember your name, who asked about attention problems. Yes, the attention problems that we see, the regulatory difficulties we see in the young infant, those regulatory difficulties continue. And regulating not only motor behaviors, but regulating attention, regulating focus, all come together to give the picture of the child with attention deficit hyperactivity disorder. Now, let me caution you here. It's often not a true ADHD. It just looks that way. In our own clinic in Chicago, we did a study, and we published it. And let me mention, I'm going to give you my website at the end. Any of the studies that I mentioned that you're interested in getting, all you have to do is contact me through the website, and I'll send you the article. We cannot post published articles, research articles on our website because of copyright laws, but if you request the article for an educational purpose, that is educating yourself, then we can send you articles. I did publish just about a year and a half ago, I think, an article on neonatal abstinence syndrome and public health policy. Also published in the last 2 years an article on marijuana use in pregnancy. The particular article I'm referring to at this point, though, we did a study. We took a sample of 3,000 children, used sampling techniques, and looked at the rate of misdiagnosis. Now, these were children that were referred into our clinic in Chicago. And we do full neuropsych evaluations, medical assessments on these children. And what we show is that in children with prenatal substance exposure, I'm trying to remember the exact, 85.6% of them, and these are, children were 4 to 18 years of age in this study, 85.6% of them had been misdiagnosed. And they were on medications that were completely inappropriate or perhaps not even needed. And by far the most common misdiagnosis was ADHD. So if you work with this population, it's probably an article you should have a look at. Self-regulation difficulties are the grounding for impulsivity, and don't forget you can get emotional dysregulation also. The third area is adaptive functioning. Adaptive functioning is the ability to take what you know and apply it to daily living skills. And this is where you get into the communication deficits, impaired social skills, abstract reasoning, concept formation. So that's all adaptive functioning. Now, I gave you all three categories. However, children with prenatal opiate exposure, in most cases, do not have deficits in adaptive functioning. And there are different tests that we use to evaluate adaptive functioning. If a child you're working with had prenatal opiate exposure and is having difficulties with adaptive functioning, then that's a sign this child was probably also exposed to alcohol. Alcohol has a tremendous impact on adaptive functioning. Early in infancy all the way through adulthood. Children with prenatal opiate exposure, the topic of our discussion today, primarily have long-term deficits in executive functioning and in the regulatory behaviors. So in the infant birth to 3, which is the population you work with, the kinds of difficulties you're going to see related to these regulatory difficulties are problems with state regulation and arousal, what many parents will describe as temper tantrums, but the question that you have to address, is it a normal temper tantrum that all 2-year-olds have, or does it go beyond what is normal? And the best way to assess that is to ask 2 questions, frequency and duration. And you'll get a sense as to whether these so-called temper tantrums fall into the normal range. You get difficulties with sleep. Sleep is a regulatory behavior. Habituation, that is being able to block out negative stimuli. The baby who gets pulled off task, who has trouble feeding because some sound in the room will distract him and he stops feeding, that inability to habituate is evident. Reflex development is delayed, and often you'll see the early reflexes, such as the rooting reflex, don't go away. We've published a study looking at the moral reaction and showed that in opiate-exposed infants, the moral reaction persists long after the normal expected cessation point. These infants have difficulty with self-soothing, attention, transitions, and again, modulation of affect, the emotional dysregulation. So that's the general picture that you see. I've tried to give you an overview today of not only neonatal abstinence syndrome, but then a little bit into what this looks like as the child begins to get older. Now, the question you have is, so what do we do about this? The different approaches that can be used have to be, first of all, grounded in relationships. And remember, the infant is going to have difficulties relating. An infant with attachment problems early on is going to have difficulty developing relationships as they get older. So you have to be very patient with these infants, because the relationship you're trying to develop with them, and you all work on a daily basis in the context of relationships, you have to focus and try to keep persisting, go slowly, but persist in developing that relationship. Sensory integration strategies are probably the single best approach to working with these infants. And I include infant massage in that and teaching the parents infant massage. And using soothing techniques that can help the infant, in fact, learn to self-soothe. If you want more information, you can go to our website. We have a lot of information, including there's a booklet on the website called Making a Difference. And we've developed it for parents, whether they're biologic, foster, or adoptive. It also would help you. And it goes through, at a very basic level, a lot of the information we've talked about, and also some parenting strategies on helping the infant make it through neonatal abstinence syndrome. We advise families when they go to a psychologist or when a doctor refers to a psychologist, you have to say, Dr. Psychologist, I want my child evaluated. And the psychologist will say, okay, we'll do an IQ test. Mostly they do neurocognitive testing and maybe a CBCL to look at behavior. But I tell parents, I tell doctors to say, no, I want my child evaluated across 3 domains of functioning: neurocognitive, self-regulation, and adaptive. And that goes for all children, not just substance exposed. But if you look at these, we didn't get into a lot of it because it applies to older children, but for instance, neurocognitive functioning looks not just at memory, but you have to look at working memory. And there's a big difference. And children with prenatal substance exposure often will look just fine on memory testing, but when you evaluate working memory, you get into a whole different picture. So the reason I presented all 3 points of the triangle is because this is what I think all children who need evaluation should be evaluated with. What I was pointing out is the main areas that you will find long-term with opioid-exposed children are the executive functioning deficits under neurocognitive and then the self-regulation problems. They, in general, do not have the difficulties with adaptive functioning, and in fact, if they get difficulties with adaptive functioning, that tells you the mother used alcohol in addition to the opiates. Remember, the most common form of substance abuse in women is polydrug use.
This was a very informative webinar. I think a lot of people really gleaned a lot of new information for them and useful information, certainly. Thank you so much for being our presenter today. We're so glad we finally were able to pull this one off. For everyone else, I just want to remind you that there will be an email that will be sent to you, and it will include the certificate, the survey for you to fill out, and once you fill out that survey, you will get your certificate. So with that being said, I think we will go ahead and end, and we will see about getting the rest of those questions addressed with the email. All right, everyone, the webinar is ended. Have a great rest of your day. Enjoy the nice weather that we have. Thanks, everyone.